Imagine for a second just having this terrifying, violent thought suddenly pop into your head.
Yeah, like a truly horrifying image involving someone you love.
Right. And now imagine that instead of just, brushing it off as a weird brain glitch, your mind totally convinces you that merely having that thought means you are a fundamental danger to your family.
The panic just completely sets in.
Exactly. The panic sets in. And the only way to prove you aren't a monster, the only way to, alleviate that crushing anxiety is to tap the doorframe exactly 7 times.
And it actually works. The fear fades.
It works. But then 10 minutes later, the thought comes right back.
Right. And this time, tapping the doorframe 7 times doesn't quite kill the panic.
No.
So you had to tap it 14 times.
Yeah.
Then 21 times until you were entirely consumed by the cycle.
That is the invisible, just exhausting prison of obsessive-compulsive disorder. And that is our mission for today's deep dive. We're welcoming you into the room with us to completely tear down the pop culture caricature of OCD.
Because it really is a caricature, isn't it?
Yeah. Oh, totally. Usually when we talk about this condition, society turns it into this quirky adjective, like someone likes their pens lined up and they say, oh, I'm so OCD about my desk.
Which is deeply frustrating for clinicians and, especially for patients.
I can imagine.
Treating it as a preference for order trivializes a condition that the World Health Organization actually ranks among the top 10 most disabling medical conditions worldwide.
Wait, really? Top 10?
Yes, purely in terms of lost income and lost quality of life.
Top 10 in the world. That completely shifts the gravity of what we're dealing with today. We have a massive stack of clinical sources detailing the history, the shifting medical definitions, and the rigorous mechanics of how this trap actually operates, and most importantly, how to break it.
Which is the crucial part.
Okay, let's unpack this, because before we can understand the escape route, we need to understand the architecture of the trap itself. So what is the clinical reality of this disorder?
Well, the clinical reality rests on 2 linked but very distinct phenomena: obsessions and compulsions. So obsessions are recurrent, intrusive, and fundamentally unwanted thoughts, images, or urges. They cause severe distress.
And they don't want them.
Exactly. The hallmark here is that the person actively recoils from the thought. They do not want it. And then we have the compulsions.
Rituals.
Right. These are the repetitive behaviors or even mental acts that a person feels violently driven to perform to reduce the distress caused by the obsession. And it's usually following incredibly rigid rules.
And the rule might be totally illogical, right? Checking that the stove is off 40 times is wildly out of proportion to the actual risk of a house fire.
The behavior is completely unmarred from objective reality.
Yeah.
And, the psychiatric community's understanding of this has evolved dramatically over time.
How so?
Well, for decades, from 1980 in the DSM-3 all the way to the year 2000 in the DSM-IV, the diagnostic manual actually classified OCD as an anxiety disorder.
Which, that feels intuitive on the surface. The panic is the loudest symptom.
It is intuitive. But it turned out to be structurally inaccurate. By 2013, when they released the DSM-5, the American Psychiatric Association pulled OCD out of the anxiety chapter entirely.
Oh, they separated it.
They did. They gave it its own dedicated category: obsessive-compulsive and related disorders. Because accumulating neuroimaging and genetic evidence revealed that the brain circuitry involved in OCD is distinctly different from what you see in panic disorder or social anxiety.
Wow.
Yeah, it's running on entirely different neurobiological hardware.
That actually brings up a fascinating point from our sources about how this hardware operates. Because when we see OCD depicted in movies, it's always visible. We see the hand washing, the flipping of light switches, the physical pacing.
The outward behaviors.
Right. But the clinical literature heavily features purely obsessional OCD and mental compulsions.
Yes, which are huge.
As I was reading through this, a specific analogy came to mind. It's like walking past a computer monitor, the desktop is totally clean, the screensaver is running, and the hardware looks perfectly intact from the outside. You just assume the computer is fine.
Right, it looks perfectly normal.
But if you were to open the task manager, you'd see a massive background program silently eating up 100% of the CPU. The machine is completely paralyzed internally.
I love that. That analogy perfectly captures the clinical breakthrough of the 1990s and early 2000s.
Really?
Yeah. Researchers, with Stanley Rackman being a pivotal figure here, they established that compulsions do not require physical movement.
So they're just in the head.
Exactly. A patient might sit perfectly still for 3 hours, but internally they are mentally reviewing a specific memory from a party over and over just to make absolutely sure they didn't accidentally say something
Or
offensive.
they're like silently repeating a specific phrase.
Right, silently repeating a prayer to cancel out a blasphemous image. Those mental gymnastics are compulsions, and they carry the exact same weight as scrubbing your hands with bleach.
Meaning someone could be dealing with severe, debilitating OCD, and to their family, their boss, or even to a doctor during a surface-level interview, they look entirely fine.
Completely invisible to the naked eye. Recognizing mental compulsions revolutionized diagnostic interviews. We stopped just looking for physical tics and started asking about that internal task manager.
So if we know the gears of this machine can be entirely internal, I want to pivot to how these gears actually lock together. Like, how does a single passing thought escalate into a prison sentence?
To understand the escalation, we have to walk through a 5-step self-reinforcing loop. This is the core mechanical engine of OCD.
Okay, walk us through it.
Step 1 is the intrusion. A thought, an image, or an urge drops into your consciousness. And the clinical data here usually shocks people.
Because everybody has them.
Exactly. Every single person on Earth has these intrusions.
I found this part of the reading so validating, honestly. The sources cited a landmark 1978 study by Rockman and Padmal de Silva.
A classic study.
Yeah, they surveyed the general non-clinical population and discovered that almost everybody experiences bizarre, taboo, and even violent intrusive thoughts.
Oh, absolutely. Plunging a knife into a toaster, swerving into oncoming traffic, suddenly kissing a stranger on the subway.
Right.
Ordinary people report internal phenomena that are, content-wise, virtually indistinguishable from the obsessions reported by patients with severe OCD.
So, if the raw material of the thought is identical, why does one person just brush it off while another develops a life-altering disorder?
That discrepancy leads us to step 2, which is catastrophic appraisal. This is the framework developed by psychologist Paul Salkowskis in the late 1980s.
Okay.
A neurotypical person has the thought about swerving into traffic, and their brain flags it as meaningless mental spam. They literally just delete it.
But the OCD brain doesn't.
No. A person who develops OCD appraises the thought as deeply, dangerously significant. The disorder isn't the presence of the thought. The disorder is the meaning assigned to it. They think, if my brain generated an image of harming my child, it must mean I secretly want to do it, and therefore I am a lethal threat.
The thought is interpreted as a fact, or like a premonition, which slams us into step 3, massive anxiety.
The distress hits a panic-level peak.
You are terrified of your own mind, and that forces step 4, the compulsion. You perform a ritual, like mentally reviewing every interaction you've had with your child, to neutralize the thought and make the distress stop.
And that leads to step 5, which is where the trap permanently closes.
Because it works.
Yes.
Yeah.
The ritual actually works. The anxiety temporarily drops.
I want to pause here because if you are listening to this and assuming that a compulsion sounds like a helpful coping mechanism since it reduces the anxiety, this completely flips the script. The compulsion isn't a coping mechanism. It is the fuel keeping the entire engine running.
It is the single most destructive part of the cycle.
It's like having a brutal mosquito bite.
Right.
When you scratch it, it feels like incredible euphoric relief for about 2 seconds.
Oh, for sure.
But the physical act of scratching is the exact mechanism that triggers your body's histamine response. Scratching makes it swell up, bleed, and guarantees that it is going to itch 10 times worse a minute later.
Yes.
The relief you feel is actively causing the damage.
Building on that biological analogy, what we are talking about in behavioral psychology is negative reinforcement. By performing the compulsion and experiencing that drop in anxiety, you are teaching your brain 2 disastrously false lessons.
Which are?
Lesson 1, the intrusive thought actually was a legitimate danger. And lesson 2, the ritual you just performed is the only thing that kept you alive.
Wow.
Your own felt experience confirms the delusion.
So the more you ritualize, the more you validate the fear.
And the stronger the neural pathway becomes. This is why patients report such profound exhaustion. In classic cases, the patient's insight is preserved.
Meaning they know they're doing it.
They know it's irrational. They know logically that tapping the steering wheel doesn't prevent a multi-car pileup. The DSM-5 notes that this insight exists on a spectrum. Some patients have good insight, others eventually become delusional. But for most, they are fully aware that the compulsion makes no sense.
But they do it anyway.
The anxiety is just so biologically overwhelming, they capitulate to it anyway. It's a relentless daily war against one's own rationality.
Here's where it gets really interesting. Because when you look back at how psychiatry historically tried to treat this loop, before we mapped out these mechanics, they used tools that actually made the trap stronger.
Oh, the historical record is a testament to how dangerous misdiagnosis can be.
Look at Sigmund Freud. In 1909, he published one of his most famous case studies about a patient he called the Rat Man, a lawyer named Ernst Lanzer.
Yes, a very famous case.
Lanzer was plagued by this violently intrusive fantasy involving a torture device with rats. And his compulsions to stave off this anxiety were just wildly elaborate. He would take these convoluted, multi-stage train journeys just to repay trivial debts.
All as a form of magical thinking.
Right, to undo the implied harm of his violent fantasy.
Freud viewed this entirely through his psychoanalytic lens. He labeled it an obsessional neurosis. Freud argued that these bizarre symptoms were essentially a defense mechanism.
Defending against what?
A way for the patient to shield themselves from deeply repressed, aggressive, and sexual impulses, usually rooted in unresolved childhood conflicts.
It sounds incredibly sophisticated on paper, but practically, it was a disaster for the patients. Why did talk therapy fail so spectacularly here?
Psychoanalysis failed because of the mechanics we just discussed. If a patient is terrified of an intrusive thought, and the therapist spends 3 hours a week having the patient obsessively analyze the hidden meaning of that thought.
Oh, no.
Yeah, the therapist is acting as a giant compulsion. They are validating the catastrophic appraisal.
By endlessly analyzing the root cause of the mental spam, psychoanalysis essentially threw gasoline on the fire.
Exactly. It taught the brain that the thoughts were indeed profoundly important.
Which means the loop just kept spinning and expanding. And the sources bring up Howard Hughes as a devastating example of what happens when the loop expands unchecked.
Howard Hughes is a tragic case.
We know him as a billionaire aviator, but his life was hijacked by severe contamination fears. Early on, he might just require his staff to use multiple sterile paper towels to open a can of food. But the nature of untreated OCD is that the safe zone constantly shrinks.
That is the trajectory. The contamination fear doesn't stay confined to sood cans, it metastasizes. Soon, the doorknobs are contaminated.
Than the air itself.
Right. Hughes eventually isolated himself entirely in darkened screening rooms, naked, unable to touch almost anything without elaborate rituals.
It's so sad.
When the compulsions fail to provide lasting relief, the brain just demands more extreme compulsions, until the rituals consume 100% of the person's waking life.
And because talk therapy was failing to stop this metastasis, mid-20th century psychiatry turned to some incredibly dark interventions.
They moved from the couch to the scalpel. From the 1940s onward, for severe treatment-resistant cases, surgeons performed prefrontal lobotomies. They were indiscriminately severing connections in the frontal lobe to blunt the patient's emotional capacity.
Just destroying the brain.
It stopped the anxiety, but only by effectively destroying the patient's personality. It is universally regarded today as a medical catastrophe.
Our sources do note that modern medicine still utilizes psychosurgery, but it is, universes away from a lobotomy.
Oh, completely.
Today, they use highly precise MRI-guided procedures like a cingulotomy, where they burn a millimeter-sized lesion in a very specific neural pathway to sever the overactive fear circuit, or they use deep brain stimulation.
Literally implanting pacemakers in the brain.
Right, to regulate the electrical impulses.
Those are remarkable advancements. But it is vital to emphasize that those surgical options are strictly reserved for a minuscule fraction of patients.
Only the most severe.
The absolute most severe, intractable cases where all other treatments have failed. For the vast majority of people, the real breakthrough didn't come from a scalpel, it came from behavioral psychology.
Right, because if psychoanalysis fed the loop and lobotomies destroyed the brain, how did we finally figure out how to open the trap safely?
The paradigm shifted in 1966 with a British psychologist named Victor Meyer. Meyer was working with hospitalized patients whose compulsions were so extreme they were washing their hands with harsh chemicals until the skin peeled off.
Just awful.
Meyer hypothesized that the only way to break the cycle was to attack the negative reinforcement. So he did something radical. He physically prevented the patients from performing the ritual.
That's the response prevention.
Exactly, and he forced them to face the trigger, like touching a contaminated doorknob. That's the exposure.
Which birthed ERP, exposure and response prevention therapy.
Yes. And Meyer documented something profound. When the patients touched the doorknob and were barred from the sink, their anxiety shot into the stratosphere. They felt like they were in mortal danger.
I bet.
But then they just sat there. And without any washing, without any ritual, the anxiety peaked, plateaued and eventually subsided entirely on its own within about 30 to 90 minutes.
The brain just realizes the house isn't actually burning down.
Clinically, we call that process habituation. Meyer proved that the compulsion isn't necessary for the anxiety to pass. The nervous system simply cannot sustain a state of maximum panic indefinitely.
And this observation perfectly aligns with something explicitly detailed in our sources, which is Hobart Mower's two-factor learning theory.
Yes.
If I'm understanding this correctly, Mower explains the exact architecture of why ERP works by breaking OCD down into two distinct phases of learning.
You're hitting on the fundamental framework of modern treatment here. Mower's theory is elegant. Factor 1 is classical conditioning.
The fear part.
Right. This is where a neutral stimulus, like a doorknob, gets mentally paired with a terrifying concept, like a deadly disease. That creates the intense fear. Factor 2 is operance conditioning.
The reward part.
Exactly. This is where the patient learns that washing their hands makes the fear go away. The relief acts as a reward, locking the behavior in place.
So Mower's theory shows us that if the compulsion is the operant conditioning that locks the fear in place, the only way out is to sever that link.
Yes.
You have to force the brain to experience the classical conditioning, the fear of the doorknob, without allowing the operant reward of washing your hands.
That is the exact mechanics of ERP. By enduring the exposure without the response, you shatter the operant conditioning. The brain learns a new overriding lesson. The doorknob is safe, and I can handle the distress.
Wow.
ERP remains the gold standard today, yielding a 60 to 85% clinically meaningful improvement rate.
But looking at it practically, ERP sounds agonizing. I mean, it's the 21st century. I know listeners are wondering, can't you just prescribe a pill that alters the neurochemistry and bypasses the agony of facing your worst fears?
It is a common question, for sure.
Yeah.
But the clinical reality is far more complex. Medication alone is rarely a silver bullet for OCD. Well, we do use SSRIs, antidepressants like Prozac or Zoloft, but treating OCD typically requires much higher doses than treating depression, and the timeline is grueling.
How long does it take?
Patients often have to endure a 10 to 12-week trial period at a high dose just to determine if the drug is having any effect at all. Ultimately, the most effective evidence-based approach is combining those medications with ERP therapy.
Do they work together?
Yes. The medication isn't a cure. It acts as a buffer. It lowers the patient's baseline anxiety just enough so that the terrifying exposure exercises of ERP become tolerable.
Got it. So the mechanics of the treatment are solid. But as we look at the broader field today, the diagnostic boundaries of what actually counts as OCD are still highly contested.
Very much so. Let's look back at that DSM-5 chapter, Obsessive-Compulsive and Related Disorders. The psychiatric community is constantly debating the OCD spectrum.
Right.
For instance, take hoarding disorder. For a long time, extreme hoarding was considered just a symptom subtype of OCD. People experience intense, paralyzing distress at the thought of discarding items.
But they don't respond to ERP.
Exactly. Clinical data revealed that hoarding responds incredibly poorly to standard ERP therapy.
Because if the core treatment mechanism doesn't work, it suggests the underlying engine might be fundamentally different.
Exactly why it was given its own distinct diagnosis. We also look at neighboring conditions that share the exact same structural loop, but focus on different content.
Like body dysmorphic disorder.
Yes, BDD. The patient is caught in the identical cycle of catastrophic appraisal and negative reinforcement, but the obsession is entirely focused on a perceived physical flaw.
Leading to compulsions like hours of mirror checking or skin picking.
Right.
Or compare it to generalized anxiety disorder, where a person experiences chronic excessive worry, but they lack the rigid, rule-bound compulsions to neutralize the thoughts.
They don't have the rituals.
Right. And then you have atachic disorders and Tourette's, which are fascinating because they frequently co-occur with OCD, but the mechanism shifts. In adectic-related OCD, the compulsions aren't necessarily driven by a catastrophic fear of contamination.
No, they're often driven by a purely physical, neurological urge to make something feel just right or perfectly symmetrical.
And exploring that physical neurological urge leads us directly into one of the most intensely debated frontiers in pediatric psychiatry today.
Yes, it does.
Because cystics have such a strong neurological basis in the brain's motor centers, researchers began asking, could sudden onset OCD have a purely physical trigger as well?
Which brings us to PANDAS, proposed in 1998 by Dr. Susan Sweeto at the National Institute of Mental Health.
Right. PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorders Associated with Streptococcal Infections.
It is a striking hypothesis. It attempts to explain cases where children develop severe overnight onset of OCD and TMICs.
Like literally waking up one morning consumed by compulsions.
Exactly.
The theory Sweeto proposed is that a common everyday strep infection triggers an abnormal autoimmune reaction. Basically, the child's antibodies get confused, cross the blood-brain barrier, and attack the child's own basal ganglia. This massive inflammation causes the sudden onset OCD.
It's a compelling mechanical explanation. But as our sources emphasize, we must remain impartial here because the science is deeply unsettled.
Very debated.
The broader phenomenon of abrupt onset OCD is clinically recognized. Today, it is generally termed PANS. But the specific mechanism linking it uniquely to strep antibodies and the subsequent treatments involving long-term antibiotics, plasma exchange, or immunotherapy are the subject of intense, ongoing clinical disagreement.
The brain is just so complicated.
The hardware of the brain is astonishingly complex, and the data is still being debated. If we connect this to the bigger picture, though, understanding the mechanics of this disorder, whether it's triggered by autoimmune inflammation or behavioral conditioning, isn't just about clinical trivia.
It completely changes how we interact with the people in our lives.
It has profound everyday applications. Think about a very common scenario. A friend or family member with OCD comes to you terrified. They ask for reassurance.
Are you absolutely sure I locked the door? Are you sure I didn't hit someone with my car on the way home? And the natural, empathetic instinct is to comfort them. You want to say, yes, I was with you, the door is locked, everything is totally fine.
But once you understand the loop logic of Mohrer's theory and negative reinforcement, you realize that providing that verbal reassurance is actually acting as a compulsion.
Oh.
You are participating in their ritual. You are providing the temporary relief that rewards the obsession.
Oh, wow. So by trying to be a good friend and alleviate their fear, you are actually accidentally tightening the trap. You're the one scratching the mosquito bite for them.
Unintentionally, yes, you are keeping the cycle alive. That is why psychoeducation is so critical for families, teaching them how to lovingly support the person while refusing to participate in the compulsion.
So what does this all mean? When we zoom out and look at the landscape of this deep dive, we are looking at a disorder with a massive footprint. The sources note that OCD affects roughly 1 in 40 to 1 in 100 adults at some point in their lives.
It cuts across all geographic and cultural lines, and it has a clear documented genetic component. Yes, twin and family studies show a significantly elevated risk if a first-degree relative has the disorder. It also has a distinct bimodal onset, meaning it typically strikes either in early childhood or in young adulthood.
And because the obsessions are so often taboo, fears of sudden violence, horrific contamination, or religious blasphemy, people hide it.
I do.
They suffer in absolute silence for years, performing invisible mental rituals while their internal world quietly shrinks, which is why public understanding is so vital. I want to highlight that our sources gave a great shout out to the author John Green.
Oh, yes, who wrote the novel Turtles All the Way Down.
Exactly. He has been incredibly transparent about his own lifelong battle with OCD, helping to dismantle these trivializing stereotypes and show the reality of the spiral.
It is vital advocacy when we replace the reductive neat freak myth with a rigorous understanding of the catastrophic appraisal loop. We move past judgment and foster genuine structural empathy.
It completely changes the paradigm. And it brings me to one final provocative thought I want to leave you with. Drawing on how our sources mention these mechanisms echoing in everyday life, because even if you do not have a clinical diagnosis of OCD, this loop logic, the pursuit of temporary relief that ultimately fuels anxiety, is everywhere.
It really is.
Think about how we consume information during a global crisis or an election cycle. We feel profound anxiety about the state of the world, so we doom scroll.
Not bad.
We compulsively refresh our feeds, seeking a moment of resolution, a final update that will make us feel certain and safe. But does that endless checking ever actually resolve the anxiety?
Never.
Or does it just keep the histamine response going? How many of our daily digital habits are really just micro-compulsions, silently fueling the exact anxieties we are desperately trying to escape?
It is a powerful question. The line between a healthy coping mechanism and a self-reinforcing trap is often much thinner than we'd like to admit.
We want to thank you so much for joining us in the room today to unpack this. Stay curious, keep questioning the hardware, and we'll see you on the next deep dive.